Nursing considerations. The woman who is diagnosed with breast cancer depends on the nurse for emotional support and accurate information. The woman needs time to express her feelings, and the nurse should convey a sense of empathetic understanding by quiet presence, touch, and close attention to the woman's concerns. Many women feel a sense of loss of control and that their lives have been taken over by cancer and the recommended treatments. Some women are concerned about family relationships and how their sexual partner or children will respond. Each woman should be encouraged to express her fears and worries. In addition to providing time and demonstrating genuine interest in the woman's concerns, the nurse should use communication techniques such as clarifying, paraphrasing, and reflecting feelings so the woman can participate in decisions about her care. Most women with a clear understanding of procedures and care experience a reduction in anxiety. Pre-operative teaching should include significant others to increase their ability to support the woman. Teaching should include the length of the hospital stay and what will happen during that time. The nurse should describe the dressings, drainage tubes, and appearance of incisions for the breast procedure or procedures being planned. Lumpectomy, mastectomy, reconstruction. Specific exercises such as arm lifts and pulley exercises may be necessary to promote flexibility in surgical areas. Lymphedema caused by blocked drainage of the lymphatic system in the arm on the side of the mastectomy is possible if most axillary lymph nodes must be removed. Lymphedema may not occur for many years and is not anticipated for women who do not require an extensive lymphatic tissue removal in the axilla. Compression arm sleeves, similar to thromboembolism deterrent hose, are an available treatment to control lymphedema if needed. Discharge teaching focuses on self-care and the need for continued care and treatment. Some areas of concern are how to reduce the risk for wound infection, care of the arm on the affected side, side effects of postoperative and adjuvant medications, and signs and symptoms that should be reported to the physician. If the woman will be discharged with the drains in place, she should be taught how to empty them. Most women also benefit from information about groups such as Reach to Recovery through the American Cancer Society that provide support, information, and guidance after mastectomy. Support groups associated with the hospital and oncology center may offer additional support. The internet may be a resource for community and online support groups. Printed information about local support groups is usually provided at discharge. Menstrual cycle disorders. The four most common menstrual cycle disorders are absence of menses, amenorrhea, abnormal uterine bleeding, pain associated with the menstrual cycle, and cyclic mood changes, including PMS. Although most of the disorders are benign, all require comprehensive gynecologic assessment. Nurses should be knowledgeable about underlying processes, diagnostic procedures, and expected treatment to fulfill the basic core of nursing activities, which include patient advocacy, education, and supportive counseling. Amenorrhea. Amenorrhea can indicate either normal physiologic processes or pathologic issues in the reproductive system. Amenorrhea before menarche, onset of menstruation, during pregnancy, during the puerperium and lactation, and after menopause is normal. Amenorrhea at other times is abnormal, and it is called either primary or secondary amenorrhea, depending on when it occurs. Primary amenorrhea. Absence of menses may create a great deal of concern for the young woman and her family. Amenorrhea is a symptom, not a diagnosis, and they may worry that it indicates a serious disease. Menstruation is a unique function of women, and absence of menstruation may provoke concerns about femininity and the ability to have children. Concern increases if a cause cannot be found or medical treatment is not successful. Menstrual periods should begin within 2 years of breast development, between the ages of about 9 and 15 years. Lack of breast development or other secondary sexual development or a shortened growth spurt in addition to the absence of menstruation provides additional diagnostic clues. Primary amenorrhea may be suspected if the girl is more than 1 year older than the ages at which her mother and sisters had menarche. Although amenorrhea may result from a number of different conditions, a systematic evaluation, including a detailed history, physical examination, and laboratory assessment of selected serum hormone levels, can usually identify the underlying cause. Pregnancy should be excluded in all cases. Ovarian failure may occur in girls who have Turner syndrome, in which only one of the normal two X chromosomes is present. They have a total of 45 chromosomes with a single X chromosome. If secondary sex characteristics are present, incomplete development of internal reproductive organs may be the cause of amenorrhea. Other causes may include hormonal imbalances, systemic disease such as cancer with its associated therapy, and abnormalities of the hypothalamic pituitary axis that results in hormone imbalance. Primary amenorrhea, which by definition is failure to reach menarche, is often the result of chromosomal irregularities leading to primary ovarian insufficiency or anatomic abnormalities. A common systemic cause of primary amenorrhea is low body weight for height. This may occur in competitive athletes and dancers, but also occurs in girls with eating disorders, such as anorexia nervosa, who have a very low body weight. If a girl began sexual development and then restricted calories, or began an intense exercise program, her sexual development may be arrested at the point of the calorie restriction. Other systemic causes of primary amenorrhea include chronic stress, hypothyroidism, abnormal steroid secretion, central nervous system diseases, and drug use, therapeutic or illicit. Obesity is often associated with insulin resistance and chronic anovulation related to high androgen levels. Abnormalities in the uterus, vagina, or hymen can obstruct the outflow of the menstrual flow. Congenital enzyme abnormalities may disable different aspects of the reproductive cycle. Medical management depends on the cause identified in a diagnostic workup. Counseling for eating disorders, such as anorexia nervosa, and reducing excessive exercise to allow adequate weight gain may prove helpful. Hormone therapy may establish normal menses if the cause is hormone imbalance. However, some conditions cannot be successfully treated. For example, if the cause is reproductive tract or congenital anomalies, normal menses and fertility may not be possible, and psychological support becomes the most important therapy. Secondary amenorrhea. Secondary amenorrhea is the cessation of menstruation for 6 months or more in a woman who has established a pattern of menstruation or absence for the duration of 3 normal cycles. In addition to pregnancy, there may be a variety of causes, including systemic diseases such as diabetes mellitus, tuberculosis, hypothyroidism, or central nervous system lesions. Polycystic ovary syndrome, hormonal imbalances, strenuous aerobic exercise, poor nutrition, use of hormonal contraceptives, and ovarian tumors also may be causes. Most cases of secondary amenorrhea can be attributed to polycystic ovary syndrome, hypothalamic amenorrhea, hyperprolactinemia, or primary ovarian insufficiency. Events such as divorce, death of a close friend or family member, moving, or job change often result in stressors that occur with secondary amenorrhea. Assessment includes a thorough medical and obstetric history and questions about eating habits, history of dieting, and current exercise pattern. Women who also questioned about their use of drugs such as oral contraceptives, phenothiazines, and antihypertensives, which can cause secondary amenorrhea. Medical treatment aims at identifying and correcting the underlying cause after ruling out pregnancy and determining whether the woman wants children. Pregnancy testing is done for a sexually active woman and medications that are potentially teratogenic should be withheld until pregnancy is ruled out. Other treatment may include testing levels of hormones related to the menstrual cycle, therapy to improve timing of the cycle, treatment of anovulation, and identification of other abnormalities that may be related to the disorder. Excess androgen levels may cause PCOS, characterized by acne and excess weight and body hair, as well as the anovulation that results in amenorrhea. Nursing considerations. Emotional support is essential if medical diagnostics are needed to evaluate the cause of absent menses, particularly if the problem is primary amenorrhea. Adolescence is a time when being different from peers is often painful, especially if a correctable cause for the difference cannot be identified. Teaching includes the importance of adequate nutrition and discouragement of rigorous dieting. The nurse should explain that although exercise is beneficial, strenuous workouts or aerobic training can cause amenorrhea. Effective weight control may reduce factors related to PCOS. Referral for psychological counseling may be needed for eating disorders. Abnormal uterine bleeding. The normal menstrual cycle was described in Chapter 3. Dysfunctional bleeding includes prolonged or heavy bleeding, menorrhagia, bleeding that occurs irregularly and often between menstrual periods, metrorrhagia, or bleeding that occurs irregularly and more frequently, menometrorrhagia, which is essentially a combination of the other two terms. Complications of an unrecognized pregnancy, such as spontaneous abortion, should be considered when making a diagnosis. Etiology. The most common cause of abnormal bleeding fall into the following 5 basic categories. 1. Pregnancy complications such as spontaneous abortion. 2. Anatomic lesions, either benign or malignant, of the vagina, cervix, or uterus. 3. Drug-induced bleeding, such as breakthrough bleeding that may occur in women taking hormonal contraceptives. 4. Systemic disorders such as diabetes, uterine myomas, fibroids, and hypothyroidism. 5. Failure to ovulate. Management. Evaluation of abnormal uterine bleeding may include a sensitive pregnancy test, coagulation studies, and tests to determine whether ovulation is occurring. Hormone and liver function tests plus tests to determine whether the woman is anemic often are done. Ultrasonography or hysteroscopy may be used to look for polyps and check the condition of the uterine lining. A common hormone treatment is progestin, estrogen, combination oral contraceptives that suppress ovulation and allow a more stable endometrial lining to form. Surgical therapy may include dilation and curettage, DNC, to remove polyps or to diagnose endometrial hyperplasia, excess normal uterine lining cells, which may be treated with progesterone to suppress excess uterine lining. Hysterectomy may be performed if the uterus is enlarged as a result of fibroids or adenomyosis, benign invasive growth of the endometrium into the muscle layer of the uterus, and if the woman does not want more children. Laser ablation may be used to permanently remove the endometrial lining without hysterectomy. Treatment of iron deficiency anemia is needed by many women with excessive vaginal bleeding. Nursing considerations. Nurses should encourage women to seek medical attention promptly when irregular or prolonged bleeding occurs. Nurses also help the woman keep a record of the bleeding episodes and the amount of blood loss. This involves keeping a calendar and noting any vaginal bleeding, spotting, menses that occurs in addition to the number of pads and tampons saturated each day. The nurse teaches the importance of nutrition and methods to reduce stress and promote relaxation. Nurses should provide support for women who fear that irregular bleeding indicates a serious disease, such as cancer. Offering false reassurance is unwise, but information about diagnostic procedures such as pelvic examination, the Pap test, and other tests is helpful. Cyclic pelvic pain. Cyclic pelvic pain should be distinguished from acute pelvic pain. Acute pelvic pain is sudden in onset and is not experienced with each menstrual cycle. It may indicate a serious disorder such as ectopic pregnancy or appendicitis. Cyclic pelvic pain occurs repetitively and predictably in a specific phase of the menstrual cycle. The most common causes of cyclic pelvic pain are Mittelschmerz, primary dysmenorrhea, painful menstruation, and endometriosis, tissue resembling endometrium outside uterine cavity. Secondary dysmenorrhea, or pelvic pain that is not cyclic, is usually related to pelvic pathologic processes. Mittelschmerz. Mittelschmerz, middle pain, is pelvic pain that occurs midway between menstrual periods at the time of ovulation. The pain results from growth of the dominant follicle within the ovary or rupture of the follicle and subsequent spillage of follicular fluid and blood into the peritoneal space. The pain is fairly sharp and is felt on the right or left side of the pelvis. It generally lasts from a few hours to 2 days, and slight vaginal bleeding may accompany the discomfort. Generally, women do not need medical treatment beyond simple explanation of the discomfort or mild analgesics. Primary dysmenorrhea. Primary dysmenorrhea is menstrual pain without identified pathologic cause. Its onset is usually 1 to 3 years after menstruation begins, when ovulatory menstrual cycles are well established, and is most common in young nulliparous women. Commonly called cramps, primary dysmenorrhea causes significant loss of school or work hours. The pain begins within hours of the onset of menses, and it is spasmodic or colicky because of increased prostaglandin secreted at this time. It is felt in the lower abdomen, but often radiates to the lower back or down the legs. Nausea, vomiting, loose stools, or dizziness may also occur. The duration of pain is usually 48 to 72 hours. 2 recommended treatments of primary dysmenorrhea provide marked relief: oral contraceptives and prostaglandin inhibitors. Oral contraceptives decrease the amount of endometrial growth that occurs during the menstrual cycle and thereby reduce the production of endometrial prostaglandins. For women who do not wish to take oral contraceptives, prostaglandin inhibitors offer relief. The most effective prostaglandin inhibitors are NSAIDs, such as ibuprofen, Motrin, Advil, and naproxen, naproxen, Anaprox. To be effective, the NSAID should be taken around the clock for at least 48 to 72 hours, beginning when menstrual flow starts. Other possible therapies include the levonorgestrel releasing intrauterine system, LNGIUS, with greatest pain relief early in the life of the contraceptive device. Simple relief measures supplement medical interventions and may be sufficient for a woman. Rest in a comfortable position and application of warmth often provide additional relief. Endometriosis Pathophysiology. Endometriosis is defined as the presence outside the uterus of tissue that resembles the endometrium in both structure and function. The response of this tissue to the stimulation of estrogen and progesterone during the menstrual cycle is identical to that of endometrial tissue. That is, it grows and proliferates during the follicular and luteal phase of the cycle and then sloughs during menstruation. However, menstruation from endometriosis lesions occurs in a closed cavity, which causes pressure and pain on adjacent tissue. In addition, prostaglandins secreted by the endometriosis lesions irritate nerve endings and stimulate uterine contractions that further increase pain. Cyclic bleeding into the pelvic cavity can cause chronic inflammatory changes that make conception and implantation difficult. The most common sites of endometriosis lesions are illustrated in Figure 27.2. The estimated incidence of endometriosis is about 10%, but the true prevalence is unknown. Some women with significant endometriosis may be asymptomatic and endometrial tissue is found on pelvic organs during an unrelated surgery. The cause remains unknown. One theory is that reflux of the menstrual flow through the fallopian tubes allows the endometrial cells to attach to nearby structures and proliferate, creating spots of endometrial tissue. Endometrial tissue has been found in distant sites such as the lungs, raising the possibility that the cells are spread by blood circulation. Spread of the endometrial cells by the lymphatic system has been implicated. Endometriosis of the anterior abdominal wall has been found after a cesarean delivery near the incision line, leading to the theory that microscopic endometrial tissue may have been implanted during the cesarean and then stimulated to grow with later menstrual cycles. Studies have also shown a familial predisposition. Most women with endometriosis are in their 30s and nulliparous, and many have had infertility problems. Signs and symptoms of endometriosis usually regress after menopause unless a woman takes estrogen supplementation. Signs and symptoms. The two major problems associated with endometriosis are cyclic pain and infertility. Endometriosis should be considered in a woman seeking infertility treatment, even if she does not have the typical pain. Pain of endometriosis differs from that of primary dysmenorrhea. Endometriosis pain is deep, unilateral, or bilateral, and either sharp or dull. It is constant as opposed to the spasmodic or colicky pain of primary dysmenorrhea. Dyspareunia, painful intercourse, may occur, usually with deep penetration. Rectal pain may occur during defecation. Diarrhea, constipation, and sensations of rectal pressure or urgency are other symptoms of endometriosis. Although causes of infertility may not be known, some factors may be retrograde menstruation, endometrium transplant via lymphatics, immunologic changes, or familial predisposition. Management. Treatment may be either medical or surgical. A woman must often weigh her need for pain relief and the desire to maintain fertility against the side effects that accompany many treatment regimens when choosing therapy. Growth and bleeding of displaced endometrial tissue depends on adequate production of ovarian hormones during the menstrual cycle. Other factors to be considered include symptom severity, desire for future fertility, woman's age, and the effect of the endometriosis on nearby organs, such as obstruction of the urinary or GI tracts. Continuous oral contraceptives for 6 to 12 months suppress endometrial tissue proliferation, particularly in a woman who desires pregnancy after medical treatment. Both the testosterone derivative danazol and gonadotropin-releasing hormone, GnRH, agonists such as leuprolide acetate, Lupron, and nafarelin cinerel interfere with hormones needed for ovulation and the menstrual cycle, creating a pseudo-menopause while taken. The woman may have hot flashes, vaginal dryness, insomnia, decreased libido, and reduced bone density. In addition, danazol may produce masculinizing effects, such as deepening of the voice, facial and body hair, and weight gain. The woman takes the drug for a varying time, often between 3 and 6 months, depending on the drug and the degree of her endometriosis. Surgical treatment of endometriosis may have different options because of the varied size, number, and location of lesions, the age of the affected woman, and whether endometriosis contributes to her infertility. Laparoscopy, insertion of an eliminated tube into the abdominal cavity, may be performed for lysis of adhesions and laser vaporization of the lesions of endometriosis. This procedure is used especially when infertility is a problem. For women with severe pain who no longer wish to have children, a hysterectomy, sometimes including removal of one or both ovaries and fallopian tubes, and removal of all lesions, offer relief. The appendix is often removed at the same time. and pathologic examination often finds endometrial tissue attached. Removal of both ovaries causes loss of their hormone production, resulting in an early menopause. Post-operative HRT may be recommended if most endometrial lesions are removed. Nursing considerations. Dysmenorrhea varies from mild menstrual awareness to incapacitating pain that affects the quality of life for several days each month. Too often the pain is belittled. It's just cramps. One of the most important nursing actions is to acknowledge the pain. I understand this is really uncomfortable, and you are concerned that you have this much pain every month. Infertility may be accompanied by the cyclic increase in pain of endometriosis. The nurse should suggest non-pharmacologic pain relief measures, such as frequent rest periods, application of heat to the lower abdomen, moderate exercise, and a well-balanced diet. The woman should avoid scheduling stress-provoking situations during the menstrual period if possible. The nurse should counsel the woman about expected effects of OTC or prescribed medications. The woman also should be instructed about side or adverse effects specific to the medications recommended that should be reported. The nurse should allow time for the woman to express her concerns about the therapy. The woman is taught expected effects of drugs given for endometriosis and about each drug's precautions and side or adverse effects that may occur. Some women benefit from information about measures that promote sleep and relaxation, and most importantly, from the knowledge that someone is available to provide support and guidance when needed. A woman may demonstrate emotional distress if she has not had all the children she desires, but must decide whether to have a hysterectomy to reduce physical pain that simpler measures have not relieved. Premenstrual syndrome. Many women notice some minor physical and emotional changes related to their menstrual cycles. However, some women have severe problems associated with these cyclic changes. PMS, also called premenstrual dysphoric disorder, PMDD, affects about 5 to 10% of women severely enough to cause significant disruption with their daily lives. Although PMDD is the official diagnostic name for the diagnostic criteria, PMS is now a term ingrained in lay culture and will be used in this chapter. After exclusion of other diagnoses, the following criteria must be met for the condition to be diagnosed as PMS. The signs and symptoms must be cyclic and recur in the luteal phase after ovulation of the menstrual cycle. The woman should be free of symptoms during the follicular phase before ovulation of the menstrual cycle, and the cycle must include 7 symptom-free days. Symptoms must be severe enough to have an impact on work, lifestyle, and relationships. Diagnosis should be based on the woman's prospective symptom recording or charting of symptoms as they occur rather than recall of symptoms that occurred in the past. Some women who have medical or psychiatric disorders have an increased intensity of symptoms during the last half of their cycles, often leading them to assume they have PMS. Examples of these are depression, panic disorder, and generalized anxiety disorder. A psychiatric illness such as bipolar disorder may have symptoms unrelated to PMS, but the two disorders may coexist. Occupational or personal stress may worsen PMS. Numerous symptoms have been ascribed to PMS, but a relatively small number make up the majority of complaints. They can be divided into behavioral and physical symptoms. Box 27.5 lists those that are most common. Several PMS diaries with varied amounts of detail are available for the woman to record her symptoms and their severity, lifestyle impact, and medications. Etiology. Although the cause of PMS is unknown, several theories of predisposing factors have been proposed. The current theory of the cause of PMS is that normal fluctuations in gonadal hormones during a cycle, chiefly estrogen and progesterone, trigger central biochemical responses, specifically serotonin. The premenstrual fall in serotonin levels occurs in most women, but a susceptible woman may show psychiatric symptoms as her estrogen, progesterone, and serotonin levels fall during the luteal phase. Most women show a rapid post-menstrual return to a feeling of well-being. Impact on family. PMS puts a consistent strain on family relationships because symptoms recur monthly. The episodes of PMS affect the functioning of the entire family. Clinical descriptions of severe family disruptions include increased family conflict, disrupted communication, and decreased family cohesion. Of particular concern is the group of women who report symptoms of loss of control, child battering, self-injury, and increased accidents. Work and social relationships may suffer. Management. Treatment of PMS is based on the symptom profile of each woman after ruling out other problems, especially psychiatric diagnoses such as depression. Supportive therapy such as reassuring the woman that PMS is a common problem that has a physiologic basis may reduce her anxiety and should be part of other treatments. Relaxation therapy has shown benefits to women with more severe PMS symptoms. Exercise has been shown to reduce PMS symptoms and also has many other benefits to a woman's health. Modifying the diet to reduce salty foods, caffeine, chocolate, red meat, dairy products, and alcohol may be helpful. Small and frequent meals may reduce mood swings. Clinical trials have shown that supplementation with calcium, 1200 milligrams per day, has some effectiveness, and that magnesium supplementation, 200 to 400 milligrams per day, is minimally effective. Carbohydrate-rich foods and beverages may improve the mood and reduce food cravings in some women. Reducing caffeine intake and taking vitamin E, 400 international units a day, during the luteal phase of the cycle may reduce breast pain, mastalgia, in some women. Evening primrose oil also may have some benefit in reducing breast pain. See box 27.6 for other complementary and alternative therapies. Women with physical, emotional, and cognitive symptoms may be prescribed antidepressant medications, oral contraceptives to suppress ovulation, or both. Estrogen therapy may relieve premenstrual migraines. Danazol taken in low doses may relieve breast pain and other symptoms. Bromocriptine, Parlodel, during the luteal phase may relieve breast pain. SSRIs taken at lower doses than those used to treat depression, such as fluoxetine Serafem, sertraline Zoloft, or paroxetine Paxil, have been shown to be very effective for most women with correctly diagnosed PMS. The SSRI may be initially prescribed for the luteal phase only. However, if ineffective, it can then be prescribed for continuous intake. Nursing considerations. Many women experience some of the symptoms and diagnose themselves as having PMS. Nurses should discourage this practice because serious systemic disease can be missed if the criteria for a diagnosis are ignored. Instead of self-diagnosis, nurses should recommend that the woman consult with her healthcare provider so a complete history and physical examination can be performed to rule out other causes or a problem that may coexist with PMS. Psychoactive drugs may be ineffective or contraindicated if a woman's true problem is not PMS. Once the diagnosis of PMS is confirmed, nurses can educate the family about lifestyle changes that may help. Nurses should acknowledge that dietary changes are particularly difficult because many women crave salty or sweet foods, which should be restricted. Women also benefit from education about expected cyclic changes. As they learn to predict the pattern of symptoms and gain a sense of control over them, symptoms often diminish. Education and support should be expanded to include the family. When the woman exhibits symptoms of PMS, family members often respond by withdrawing or confronting the woman. Family members also should be encouraged to express their feelings so anger and resentment within the family can be minimized. Nurses should help the woman make concrete arrangements to obtain relief when she feels she is losing control or when she fears that she may harm herself or a child. Neighbor, friend, or family member should be identified to provide immediate relief without questions or explanations when the woman feels she is losing control. It is more helpful if the family acknowledges feelings they believe the woman is experiencing. For instance, saying, "It must be disturbing to feel so irritable. What can I do to help?" provokes a different emotional response than comments that are confrontational or blaming. Elective termination of pregnancy. Elective termination of pregnancy, also called induced abortion, is a voluntary method of ending a pregnancy at the request of the woman, but not for reasons of impaired maternal health or fetal disease. Therapeutic termination is usually performed to preserve the health of the mother, to prevent the birth of an infant with severe birth defects, or to end a pregnancy caused by rape or incest. A woman may choose elective termination of pregnancy for a variety of reasons, possibly economic or social. Therapeutic and elective abortions involve many social and ethical issues. Recent abortion surveillance may be found at cdc.org. Methods of elective termination of pregnancy. The technique used to terminate a pregnancy depends on the length of gestation. Abortion techniques based on medications may be options within 7 weeks of the woman's last menstrual period. Inducing uterine contractions with specific medications to end pregnancy early makes the process more private, eliminates risks such as uterine trauma or perforation, and does not require anesthesia. Drugs that may be used in medical abortion regimens to terminate a pregnancy up to 9 weeks include the following: mifepristone, Mifeprix, or RU-486, an anti-progesterone drug, followed by misoprostol, Cytotec, a prostaglandin drug commonly used to reduce gastric acid secretion. Oral or vaginal use of misoprostol in medical abortion is unlabeled by the manufacturer. The woman usually expels the early pregnancy within 14 days of her first visit. Methotrexate, Folex, Mexate is an anti-metabolite also used to treat certain types of cancer. Although not approved by the U.S. Food and Drug Administration for medical abortion, individualized doses have been successfully used for medical pregnancy termination. Misoprostol may be prescribed to enhance expulsion of uterine contents. Surgical abortion techniques are needed if the woman has been pregnant for more than 7 weeks, or if her medical abortion failed and she still desires pregnancy termination. Through 12 weeks of gestation, vacuum aspiration with curettage is a method of choice. The cervix is dilated after locally injecting anesthetic in the area, and a plastic cannula is inserted into the uterine cavity. The contents are aspirated with negative pressure, and the uterine cavity may be scraped with a curette to ensure the uterus is empty. Cramping may last 20 to 30 minutes after the procedure is completed. Complications may include uterine perforation, hemorrhage, cervical lacerations, and adverse reactions to the anesthetic agent. For second trimester abortions, cervical dilation with removal of the fetus and placenta is generally performed. The procedure is similar to vacuum curettage but requires greater cervical dilation and a larger aspirator because the products of conception have grown in size and should be removed gradually. Dilation begins with insertion of laminaria, rounded, cone-shaped materials that absorb water, into the cervix 24 hours before the procedure. Other osmotic dilators include Dilapan and Lamisil. The laminaria draw fluid from the cervical canal and expand, causing the cervix to dilate slowly and with minimal trauma. If needed, before aspiration and removal of the products of pregnancy, additional cervical dilation is done. Medical methods exist for abortion in the second trimester, but these involve labor. Retention of the placenta often occurs, requiring a D&C to fully clean the uterus. Laminaria are inserted about 12 hours before the procedure to start cervical dilation. Prostaglandin E2, which stimulates contractions, may be given via vaginal suppository or intraamniotic infusion. Oxytocin is not effective at starting labor because of the early gestation, but it may shorten labor after it has been established by other methods. Because of the emotional distress caused by the longer procedure and the increased risks involved, medical termination of pregnancy is not often chosen in the second trimester. Nursing considerations. The nurse's role in caring for women seeking elective abortion is one of providing physical and emotional support and information. History taking and collection of laboratory data depend on the routine of the healthcare setting in which the nurse is functioning. Counseling and lending emotional support are nursing responsibilities, although a designated counselor also may perform these services. Nurses are also responsible for providing information about self-care after an elective abortion. Self-care is similar to that after spontaneous abortion or miscarriage. Observation for excess bleeding or signs of infection, temperature that greater than 37.8 Celsius, 100 Fahrenheit, foul-smelling vaginal drainage. Nurses also provide information about follow-up visits and contraception. The Rh-negative woman should receive rhodimmune globulin RhoGAM. Menopause. Menopause means the end of menstruation. However, most people use the term to include the array of endocrine, somatic, and psychic changes that occur at the end of reproductive period. The entire process, often called the change of life, is correctly termed the climacteric. Premenopause refers to the early part of the climacteric, before menstruation ceases, but after the woman experiences some of the climacteric symptoms, such as irregular menses. Perimenopause includes premenopause, menopause, and at least 1 year after menopause. Postmenopause refers to the phase after menopause, when menstrual periods have ceased. Unexpected postmenopausal bleeding should be investigated as soon as possible because it suggests endometrial cancer. Conversely, planned or scheduled postmenopausal bleeding is generally not a cause for concern. It occurs when the woman who takes estrogen and progesterone sequentially stops using the drugs, usually once a month. This allows the uterine lining to be sloughed and prevents endometrial hyperplasia. Age of menopause. The average age for natural menopause is 51.5 years. The natural climacteric takes place over 3 to 5 years. Menopause can be induced or created artificially, however, at any age. Surgical removal of the ovaries or destruction of the ovaries by radiation or chemotherapy causes abrupt, permanent cessation of ovarian function, including the production of estrogen. The most common reason for performing these procedures is treatment of cancer or endometriosis. Young women who experience artificial menopause often have more symptoms associated with menopause than do women who go through the process naturally because theirs is not a gradual process as it is for the older woman. Women can now expect to live another 30 years or more after natural menopause. During this period, they must deal with physical, psychological, and social changes that often require a reevaluation of their primary roles and restructuring of personal goals. Physiologic changes. During the normal reproductive cycle, the ovaries respond to gonadotropins, follicle-stimulating hormone, and luteinizing hormone, in a predictable pattern. 1. A follicle matures. 2. The ovary secretes estrogen. 3. Ovulation occurs. And 4. The corpus luteum produces progesterone. During the premenopausal period, however, the ovaries are less responsive to gonadotropins. Although increased amounts of follicle-stimulating hormone are secreted, ovulation is sporadic and menstrual periods are irregular. With progressive aging, the ovaries become unresponsive even to high levels of gonadotropins, and ovulation, menstruation, and the secretion of ovarian hormones, estrogen and progesterone, cease. Estrogen is responsible for the secondary sex characteristics of women. When estrogen levels decline, the organs of reproduction undergo regression. The labia become thin and pale, the vaginal mucosa atrophies, and vaginal tissue loses its lubrication and therefore is easily traumatized. Dyspareunia is common, and bacterial invasion of the epithelium may occur and lead to frequent vaginal infections. The entire process is referred to as atrophic vaginitis. Breasts become smaller, and atrophy of the uterus and ovaries occur. However, a concurrent benefit is that uterine myomas, fibroids, and endometriosis lesions also atrophy. Estrogen deficit can result in atrophic changes in the bladder and urethra that may cause loss of urethral tone and frequent atrophic cystitis. In addition, absence of estrogen is associated with an adverse change in serum lipids. Serum levels of low-density lipoproteins, LDLs, which carry cholesterol to blood vessels, increase. At the same time, levels of high-density lipoproteins, HDLs, which are known to carry cholesterol to the liver and protect against the development of CAD, decrease. Many menopausal women experience hot flashes or flushes, which are the result of vasomotor instability. The cause of vasomotor instability is not known, but is closely associated with increased secretion of gonadotropins. Hot flashes are characterized by a sudden feeling of heat or burning of the skin followed by perspiration. They occur more frequently during the night, and fatigue as a result of interrupted sleep is a major problem for some women. Hot flashes are often more frequent and severe in younger women who undergo the climacteric, particularly if loss of ovarian function was abrupt because of medical therapy. Many women in the climacteric have few annoyances from hot flashes, however. Physiologic responses. It is easy to understand why menopause is called the change of life. It is accompanied by physical, psychological, and social changes, and individual responses vary widely. Many women are relieved that their childbearing and child-rearing tasks are ending. They see this as an exciting time when they can pursue personal development. Other women grieve the possibility of childbearing is past. It may be particularly true for women who have never had a child, whether because of infertility or because of lack of a male partner. However, artificial reproductive techniques have blurred the line that defines the age at which it is not possible to bear a child. Menopause requires a woman to come to terms with aging. It may be difficult to accept aging in a society that reveres youth, and many women become extremely concerned with measures that slow the signs of aging. Many women become grandmothers at this time, which also confirms aging and requires a major adjustment in how the woman views herself. A large population of baby boomers, those born from 1946 to 1964, have entered menopause. These women are likely to change many of society's ideas about menopause because of the sheer size of their group, because they have changed the social fabric of the United States dramatically as they have grown up and matured. Some symptoms do not have a physiologic explanation, but they are no less real to women who experience them. Depression, mood swings, irritability, and agitation are common climacteric complaints. Insomnia and fatigue are often mentioned as major problems. One of the most puzzling aspects of menopause is the wide variation in both physical and psychological symptoms that women experience. For some women, the only changes are mild and frequent hot flashes and amenorrhea. Other women experience severe debilitating hot flashes, atrophic vaginitis, and multiple psychological symptoms such as irritability and prolonged depression. Therapy for menopause. Although many women comfortably undergo the age-associated change in menopause, others seek relief for discomforts such as hot flashes, interrupted sleep, or vaginal dryness. Psychological perception that increasing reproductive hormones might slow the aging process and promote a more youthful appearance has strengthened use of HRT during the climacteric. Additional beneficial effects were thought to be a reduction in CVD, colorectal cancer, breast cancer, and osteoporosis, as well as other medical surgical conditions associated with aging. As greater research emerged, risk factors as well as benefits of hormone therapy emerged. Two groups of perimenopausal women were included in the hormone studies of the WHI research as follows. Estrogen and progesterone were given to women with a uterus. Combining progesterone with estrogen therapy prevents uterine hyperplasia, a precursor to uterine cancer in this group. Estrogen therapy alone was given to women who have had a hysterectomy because uterine hyperplasia is not a risk. The combination of estrogen and progesterone replacement is usually called hormone replacement therapy, HRT, whereas the estrogen-only replacement therapy may be called estrogen replacement therapy, ERT. It is common to see HRT used for either or both therapies, however. The WHI and other hormone replacement studies showed increasing evidence that estrogen plus progesterone therapy significantly increased risks for some disorders, primarily breast cancer and heart disease. The estrogen progesterone 1 arm of the WHI study was stopped in 2002. A woman enrolled in the estrogen progesterone arm was not obligated to stop taking estrogen progesterone therapy, but she had to make choices based on both the benefits and the unexpected risks that emerged with the early results. Rather than receive estrogen progesterone supplements through the study, the woman could continue the combined hormones via prescription from their healthcare provider. The estrogen-only arm of the study continued until 2004, when an increase in strokes among this group was identified. Although once routinely prescribed to reduce the annoying changes of menopause for many women, the decision about hormone therapy is more complex because both the benefits and the risks associated with prescribed hormonal drug should be considered. In addition, complementary therapy often has a greater usefulness for women having mild menopausal changes. Risks. HRT was not considered safe for all women before the WHI findings. For example, women who have had estrogen receptor positive or progesterone receptor positive breast cancer or blood coagulation disorders influenced by estrogen or progesterone do not qualify. A woman who has had breast cancer may take a drug to block the effects of estrogen and reduce the risk of recurrence. Likewise, a woman who has a close family history of breast cancer might not want to take it. Unexplained uterine bleeding and endometrial cancer are contraindications. Smoking, hypertension, diabetes, CVD, and renal or liver disease are often contraindications for hormone therapy. Whether therapy includes both estrogen and progesterone or estrogen only. Other possible contraindications include seizure disorders, migraines, and gallbladder or pancreatic disease. Nursing considerations. Nursing care focuses on helping women understand the physical and psychological changes that may occur during perimenopause. If the woman chooses hormone therapy, nurses should reinforce the prescribed regimen and the risks and benefits of the therapy. For instance, women should be told that although HRT effectively treats atrophic vaginitis and reduces dyspareunia, it may not correct the loss of libido that some women experience. If HRT is contraindicated, nurses are often the primary source of information about measures that reduce problems and promote comfort, as follows. Using water-soluble lubricants such as KY Liquid, KY Silk E, Lubrin, or Replens to relieve vaginal dryness and dyspareunia. Oil-based lubricants should not be used because they adhere to the mucous membranes for long periods and provide a medium for bacterial growth. Discussing alternatives to estrogen. such as botanical preparations, if the woman does not want ERT. The woman should discuss these with her healthcare provider because some have side or adverse effects or interactions with other drugs. Research is often minimal for these therapies. The website for the National Center for Complementary and Alternative Medicine of the NIH contains updated information. Doing Kegel exercises to increase muscle tone around the vagina and urinary meatus and counteract the effects of genital atrophy. Drinking at least 8 glasses of water a day decreases the concentration of urine, flushes urine from the bladder, and reduces bacterial growth, thereby preventing atrophic cystitis. Wiping from front to back after urination and defecation reduces the transfer of bacteria from the anus to the urinary meatus and helps prevent cystitis.